The following PowerPoint is a wonderful resource to review taking care of patients receiving oxygen therapy. Here you have your learning objectives, which you should already be familiar with. Being able to collaborate with the interdisciplinary team, educating both patients and caregivers on safety concerns about oxygen therapy or tracheostomy therapy at home, prioritizing evidence-based care for the patient requiring oxygen therapy, nursing interventions to decrease the psychosocial impact requiring oxygen and or tracheostomies. Now, tracheostomies will be new to you, and they are covered on the next PowerPoint. But we will be going through this PowerPoint very quickly because it should be a review to you. So, first of all, assessment. When you're assessing someone who is experiencing shortness of breath or they're having difficulty breathing in some sense, you will see the following assessment findings. They may be short of breath. They may be sitting in the tripod position. They're using their accessory muscles to breathe. They're using either pursed lip or diaphragmatic breathing. Their respiratory rate may be elevated, tachypnea. You may see a decrease in endurance, an increase in their dyspnea. So, what does oxygen therapy do? It relieves hypoxemia. The goal is to use the lowest fraction of inspired oxygen for acceptable blood oxygen levels without harmful side effects. Now, with this being said, ABG analysis, which we'll be learning in class, is the best measure to determine the need for oxygen therapy and evaluate its effects. But a quicker, non-invasive monitoring, such as pulse oximetry, will get you your results much quicker than the lab test. Hazards when using oxygen therapy: remember combustion. Although oxygen does not burn, but it enhances combustion so that fire burns better in its presence. With that being said, remember that people on oxygen therapy are not to smoke in their rooms or in their homes, and you want to use ground plugs for electrical equipment. Hypercapnia. With that being said, this is retention of CO2. We'll be talking about this more in the upcoming weeks with chronic lung disease. Remember, the hypoxia drive theory has been disproven. You want to still use the lowest liter flow needed to prevent hypoxemia. Oxygen toxicity. Oxygen toxicity is related to the concentration of oxygen delivered, duration of oxygen therapy, and the amount of lung disease present. Again, with prevention is using the lowest amount of oxygen needed to maintain gas exchange. Absorption atelectasis. This occurs when high oxygen levels are delivered. Nitrogen is diluted and oxygen diffuses from the alveoli into the blood, and the alveoli collapse, causing new onset of crackles and decrease in breath sounds. Prevention, again, is using the least amount of oxygen needed. Complications with oxygen therapy: drying of the mucous membranes. With that being said, remember, anytime you have an O2 flow rate greater than 4 liters per minute, you want to use humidity to prevent damage and to maintain skin integrity. With that being said, infection: the humidity can be a source of bacteria. So you want to make sure that you are changing the humidified oxygen equipment per your agency's policy. There are many different types of oxygen delivery systems. This is not new information to you. So I'm going to fly through these very quickly. I want to make sure you need to be aware of what the oxygen delivery systems are and how to care for patients with these oxygen delivery systems. You have low flow oxygen, which is nasal cannula, can be a simple face mask or a partial rebreather. Here you have someone using a nasal cannula. A simple face mask can deliver 40 to 60% It's a minimum of 5 liters per minute. Remember that the mask must fit securely over the nose and mouth. Partial rebreathers, move it up a little bit, making it 60 to 75% with a flow rate between 6 to 11 liters per minute. The thing with the partial rebreather is that 1/3 exhaled tidal volume with each breath because you have that inflated reservoir bag. The non-rebreather is the highest oxygen level that can be delivered without high flow oxygen. This can deliver an FiO2 greater than 90%. It's used for unstable patients who are going to probably require intubation or at least use of BiPAP. High flow oxygen systems. High flow oxygen systems can deliver 24% to 100%. This includes your Venturi mask, face tents, aerosol masks, tracheostomy collars, and T-pieces. Now, here you have a picture of what a Venturi mask looks like. The adapter is located between the bottom of the mask and the oxygen source. This delivers a precise oxygen concentration and is the best device for someone with chronic lung disease. Remember to switch them to nasal cannulas for meal times, but the reason this is more effective is because you can give such a precise concentration of oxygen. The T-piece we'll be talking about more when we look at tracheostomy tubes, delivers a desired FiO2 for the tracheostomy or the ET tube. It ensures humidification through the creation of mist. Mist should be seen during inspiration and expiration. And I have one of these set up very nicely in our simulation lab. And when you come for your new skills day, we'll go over this. Non-invasive positive pressure ventilation. This can be either BiPAP or CPAP. You'll be seeing this again very soon when we do our non-infectious upper airway disease processes with sleep apnea. CPAP delivers a set positive pressure throughout the cycle of inhalation and exhalation. It opens collapsed alveoli. It's used for atelectasis after surgery, cardiac-induced pulmonary edema, and sleep apnea. This is a TTO, is a long-term delivery system that is placed directly into the lungs through a small flexible catheter. It is passed into the trachea through a small incision. It avoids the irritation of nasal prongs and is more comfortable. The flow rates are prescribed for both activity and for rest. When you have someone who has home oxygen therapy, you want to make sure that you have the criteria for equipment, and it's different with different insurance companies. May say that they have to have shortness of breath, they have to have a certain O2 saturation when ambulatory or at rest. Patient education is making sure they understand how to use their compressed gas in the tank or cylinder, or their liquid oxygen reservoir, or the oxygen concentrator. The picture with the gentleman walking in the hospital is a gas tank or cylinder, where the gentleman who is out boating is using an oxygen concentrator. We will be going over some oxygen therapies again with our lecture on COPD. With that being said, the different oxygen apparatuses should not be new to you. We will be looking closer at the T-piece when we look at tracheostomies, both in the simulation lab and with the next PowerPoint.